Greetings, everyone, and welcome to our webinar today. I know a group of you are logging in and joining us. I know everyone's busy, and so just want to thank those of you who are able to join us today and for our webinar on addressing substance use within an integrated care setting. My name is Nick Szubiak, and a little bit about myself and NSI Strategies. NSI Strategies provides consulting support specific to integrated care environments. It's specifically tailored to the work that we do in integrated care, which is a little bit different and specific. And a little bit about me. My background began in behavioral health in New York City when I was a case manager for people with HIV/AIDS. I did that work for a bit and then went on to get my MSW from my home state at Rutgers in New Jersey. And then most recently, before I started doing consulting work a few years ago with the National Council for Behavioral Health and the Center for Integrated Health Solutions, I worked for 6 years as the Behavioral Health Director for an FQHC. So I'm very excited to be with you all here today. And just to give us a overview of what we're doing, and webinars are always difficult and challenging for us, right? We have a lot going on, and so folks will be multitasking in and out, and we understand that. And so our objectives, if there's a specific area that you want to focus in on, we'll be following this format. So addressing substance use disorders on an integrated care team, how that really works. We're going to take a look at substance use screening tools for integrated care environments. What's the best, what works best for us. And then a lot of us are working and familiar with SBIRT, but really talking about how to make SBIRT stick, how to make it part of our healthcare culture. And then why our environments as integrated care environments are really ideal settings to implement MAT. Many of you are maybe on that journey, have started that work, and really can enhance and raise our own level of integration. And so we'll go over what our care teams need to know to effectively implement MAT. And then really kind of to summarize our work today, talking about integrated care teams, how they are really effective in addressing a lot of different types of chronic health conditions. And we'll touch on that a little bit around substance use, but also diabetes, hypertension, and chronic pain. So to kind of get us started, you know, treatment for substance use disorders really is exciting because it challenges us to shift into treating addiction for really what it is: a chronic health condition, a neurobiological behavioral disorder. Historically, for many reasons, we've taken addiction out of the healthcare continuum, and we have suffered for it. And so now we're going to go ahead and bring addiction back in, and integrated care is a great way to do that. And so really the idea is that treatment, when we think about treating substance use disorders as a chronic health condition, as treatment is better than no treatment. So being able to get treatment, provide treatment in some way is so effective. And we know that detox alone is not effective. In fact, it's dangerous, especially right now with the opioid epidemic. Detoxing someone actually puts them at greater risk for overdose death. And we know that rapid admission, the faster we can get folks to the care that they need, the better they engage in treatment and the better it is for all. And the idea that there's no single approach, that really individualized patient-centered care is so important for treating chronic health conditions, and effectiveness in being able to enhance our ability to provide care by providing fast, immediate access, retention and treatment, and really looking at and becoming experts in focusing in on a patient's readiness to change and matching that treatment plan with that readiness, which improves client satisfaction. So these are all components of treating chronic health conditions, but are extremely effective in treating substance use disorders. So even if like many of us in our primary care settings, aren't exactly confident, comfortable in treating substance use disorders. We actually know a lot more sometimes than we give ourselves credit for, because the models that we have that are the base of how we provide care are so effective when treating SUDs, when treating substance use disorders. So it's different, but it's a lot more of the same. And so the idea is that we take treating addiction out of a crisis or an acute approach, and we start to treat it across a continuum. And integrated care models are really good at doing this, that we can really think of a hub and spoke model where we are the hub for the patient, and they can get the care that they need, moving in and out of that level of intensity or frequency or duration of the services that they need according to what they need, not according to what a set program that is set for all requires of them. So that is really changing the way we treat addiction across the country. And then focused on counseling and behavior therapies. That's something we're very comfortable doing, bringing those things together, and then focusing on interventions to enhance readiness to change and patient engagement. And then also bringing behavioral health and the medicine side of things together, right? And we're going to talk later about MAT, but medications combined with interventions we know are so effective, that our approaches to care are truly patient-centered, that they're truly strengths-based, that the patient is driving the goals of our treatment plan, our integrated plans, and that it's individualized, that like I said, the duration, the intensity, the length of care really is being driven by the patient as to what they need and when they need it, which may change across that continuum, and that we have the ability in integrated care to address multiple co-occurring disorders, right? Being able to offer a multitude of services under one roof is so important. So we are built for this. We have all these different members with unique skills, unique skill sets on the team, with the patient at the center, able to provide support for patients with substance use disorders. And we have the model to follow it. And so there's some things that we can do to kind of help support our integrated care environment to really get ready to feel confident and effective in talking about substance use disorders. And a great way to do that is through SBIRT. So we're not going to dive totally into SBIRT. We're gonna really focus today just on the screening tools. But we talked about what's the best tool, and really what it comes down to is the best tool is the one that meets the criteria here on our left. On our right, if you're looking at the slide, that these are some of the evidence-based tools that are commonly used to screen for substance use. But the best tool really is the one that first is evidence-based, and two is effective because it doesn't take a lot of time. And a lot of reasons why something doesn't take a lot of time is that it has an ease of use, that it's embedded in your EHR. And that's a game changer. So if you're using a screening tool, unfortunately, sometimes that's dictated by what tool we have or can get into our EHR. And so the idea is the best tool is the one that I can administer, the one that I can use to screen, even if it's not the one maybe that we want to use. That's a real significant weight that we have to consider when we choose that screening tool. And then from that, can we get the information? Can we get the data? Because the data, as we're going to talk about in a little bit, is a key piece to making SBIRT stick. And it gives us the information so that we can get back to our providers to let them know how they're doing. So the idea is, do I know also what to not just do with the data results, but also with our patients? Can I provide the results in a way where I feel confident to talk about substance use disorders? So really, that's the criteria that we want to use when we think about the best tool. But there is one tool that we know is being recommended that's more effective. I was lucky enough to sit on the expert panel for a change guide. You can see it in your right-hand corner. There's a link to it And the PowerPoint slides are going to be available. I forgot to mention that earlier. We'll be sending out a link. They're available on the NSIstrategies.com website. But this is a group of experts in primary care and integrated care that got together and said, what can we do to put together guidance to help support our health centers in implementing SBIRT? So there's a great resource. But this is the Audit C, and the Audit C is recommended because it meets a lot of that criteria that we looked at earlier. It's fast, it's quick, it's evidence-based, and it really gives us a good idea of where we need to go with our patients. So if we take a look at, on this screen here, this is a little bit of how we would ask these questions and how we rate them. How often do you have a drink containing alcohol? We fill out this and measure circling or inputting the data to get a score that, that would then give us some guidance about what we needed to do. But first, one of the things that I think is really important, I'm not going to go through the whole entire screening tool. You guys can take a look at that. If you have any specific questions, you guys can feel free to reach out to me. But an important component that sometimes we forget when we talk about screening is really helping educate not just our patients, but also our staff of what we mean by how many drinks are you having and what is a drink and who's counting those drinks. And so this is a really great way to make sure that all the staff understand there's a lot of different resources that you can get. You know, just download PDFs, versions of this stuff. This is off of the NIH website. But taking a look at these two screeners, or not screeners, but tools that help us understand what we mean by a drink. And it's important to note that we look at the number of ounces on the left-hand side. A lot of times, depending on our culture or where we live in our community, one drink may equal a 40-ounce beer. That's certainly something that we want to investigate more. And it's also interesting to look over on the right-hand chart that and the differences between men and women, and also on any single day, no more than 4 drinks in a day, and per week, no more than 14 drinks. So you can't do your own math and bank drinks and say, well, I'm going to use them all in one day. There's a differentiation between daily use and then weekly use. And so it's really important for us to understand as we go through. And like I said, you go through the Audit C, and it gives us some results, and this helps give us guidance of what we need to do with that result. So for the guidance here is that if we're getting a negative screen, which is 0 to 1 points, is that really we want to provide anticipatory guidance, which means that we're really talking to our patients about what a great job they're doing, how this is an important part of them maintaining the wellness and the health and the lifestyle that they want. And then as we move on to the Audit C, where for women 3 to 6 points, men 4 to 6 points, that becomes a positive screen. And then we want to enter into what we would provide as a brief counseling or a brief intervention in SBIRT. And so beginning the conversation, by building rapport, developing a relationship with the patient, providing feedback on the screening, talking to them, bringing it up and saying, hey, I'm concerned about your screening results. Can we talk about that? And then after we have rapport, after letting them know about the screening, providing advice or recommendation, and then supporting the patient and maybe setting up a goal to maybe reduce that use. Of course, that's the best case scenario. This is patient-centered. And so sometimes the best we can do is just bringing those things up in a BI, knowing the patient's going to come back because we've built that relationship and we're building an environment where it's safe for them to talk about their use. And then a higher positive screen is 7 points or higher. Concerns about these things is that we're going to want to elicit symptoms. And so now we're starting to get into potential diagnosis, looking at the DSM-5 criteria. Maybe we want to recommend or connect the patient with ongoing counseling. This would lead us into the RT component of SBIRT. So this is a great way for our staff to kind of have a guidebook or guide map or directional what to do when we get those positive screens. And so for adolescents, we recommend the S2BI, also part of a work group with the National Council right now that's developing a change package, which is the recipe cookbook for how to do the best recommendation for adolescent SBIRT. Very exciting. We're testing it. It's going to be out in a year or so. But the screener that comes out as the best screener to use is the S2BI. And one of the reasons is it's quick, it's fast, and it's practical for short visits, which we know that's how we're seeing most of our patients and our adolescents. It includes questions on tobacco, alcohol, and marijuana, and it really connects well with the DSM. So kids who reported with the DSM criteria, so kids who reported use once or twice in the past year, very unlikely that they're going to have a substance use disorder. That's good for us to know. Those who report monthly use, they're going to generate a potential for meeting criteria mild to moderate. It's one of the great things about DSM-5. There's a lot of controversy that DSM-5 lowered their criteria. People said, my goodness, everyone's going to get diagnosed as mild. That's not been the case. But it also, I think, speaks to the stigma bias of why we don't want to label people versus, gosh, don't we need to identify our kids who have mild to moderate substance use disorder? So, really our view and our judgment and our evaluation of how we think about substance use disorder really heavily influences how we address it. And those adolescents that report weekly use most likely are going to meet that criteria for a severe substance use disorder. And so this is a quick look at the craft on the left-hand side. It asks the big three. That's why it's so fast. We know that if we ask our adolescents and cast the net of screening and ask those three questions, tobacco, alcohol, and marijuana, we will make sure that in our net we catch 80% of our kids. 80% of our kids who need to have further conversations like a BI, like a brief intervention, or an RT. And so this is our logarithm on the right in terms of how we want to interpret the screening. That no use doesn't mean we don't talk to our kids about it. We want to reinforce that positive behavior. We want to talk to them and say, great job, this is helping you, this is supporting you, this is a good thing that you're doing. Once or twice, we're moving into the brief intervention, those taking those steps to talk to our adolescent, developing rapport, and then as we move on up, then we're moving into referral to treatment. So that's a good look at really kind of how we can guide for adolescents our use. So one of the things that I hear quite a bit when we're implementing SBIRT is that, we're going to open up the floodgates. If we start screening all of our patients, we're just going to get overwhelmed. And how are we going to handle all of our patients, and how are we going to address all of these needs? And so it's really interesting. There was a huge research study done with across the country, several different levels of primary care, but it was a huge number that were researched. The link to the research is in the slide down here. But what came out of this is that what we learned is when we start screening over here, when we start screening your primary care population, what comes out, what happens is that 40% of the patients that we screen are abstinent to low risk, meaning that we want to provide that anticipatory guidance, that we want to say, hey, this is a great job. Continue doing this. And then 35% move into that subtly higher category where it's moderate risk, where we want to start having a brief intervention, starting that conversation to talk about concerns about their use and educate them about the impact it may be having in other areas of their life. And then when we move into high risk, that's even less. It's 20% of the patients, which still leaves us in the BI realm where we're talking about a brief intervention, which can be done very quickly. And then 5% are that moderate to severe level where we're looking at referrals to treatment. Typically, the 5% is what we think of as the typical example of screening, when it's far from it. It's a very small percentage. Granted, that 5% if you're a primary care provider and that comes up in your day, certainly can take a lot of resources and a lot more time. And typically they're the examples that we think of as the norm, but they certainly are not. So as we look at our chart here, our SBIRT target population, the folks that we're really focusing on is our 20 to 35% over here, this entire part of the chart, that are only requiring a BI. And I say only, that we know in primary care that we can do a brief intervention in a minute. It's really about acknowledging it, bringing it up and talking about it. We don't always love the word intervention. I think it conjures up a lot of images of people confronting someone in a room with a bunch of chairs around them sitting in the middle or at the head. And that's not what the brief intervention is at all with SBIRT. It can be a quick raising of the issue, eliciting some information, connecting with the patient, and starting the conversation around their substance use. And so we see that really that 40% is an opportunity for us to be proactive in SBIRT treatment with primary prevention. And really that 5% is the referral to treatment. So truly, there is no flood. We're not opening up the floodgates. There is no flood. It's really been cool too in the adolescent SBIRT project that I said that I was working on with the National Council, is this data is also showing up in our health centers, where that moderate to severe is really in this lower range. So the research has been really cool how the research is held up in that area. So why do SBIRT? Well, we know that SBIRT is a way for us to really start to educate ourselves in primary care about substance use disorders. Many of us avoid it in primary care because we haven't had the training, whether we're primary care providers, whether we're social workers, psychologists, nursing staff. All of us have really not gotten the training that we need to feel comfortable with SBIRT. So SBIRT is a way that we can start to improve our overall clinical care by improving our proficiency and being able to start to talk about it. So in that way, it starts to transform our culture. And really, SBIRT implementation is preparing our workforce for healthcare changes. Being able to implement something like an SBIRT program where you're implementing a screening tool, you're starting to get data, you're providing feedback, you're adjusting workflows, all that really prepares our health center for the next change, the next thing that's coming, all the different changes that we need to adapt to in integrated care. Also begins to prepare us and our organization for the future. And the future is value-based payments, where we're not paid primarily on the number of services that we provide, but we're paid and going to be paid on the overall health and wellness of the patients that we serve. Addressing substance use disorders is an incredible opportunity to do that. Our top 3 causes of accidental death in this country both include substance use disorders. Number 3 is alcohol. Number 1, tobacco. Those are some of the best things that we can do for our patients to help them in their lives and their wellness, is addressing their substance use. And SBIRT is a way to do that. And so SBIRT expands our reach into new audiences. We can start screening and identify patients that we normally maybe didn't know had a substance use problem. And adding that in as a way to make sure that our patients are getting the support and services that they need. And it really helps change our clinic culture of treating substance use disorders as a biobehavioral chronic health condition. So how do we make it stick? How do we get SBIRT to stick? And really, it's about our culture. And there's the saying, you may have heard it, that culture eats strategy for breakfast. What that means is that if we don't address our culture and start to educate and provide support for our staff to feel proficient and confident and understand substance use disorders, we won't make the change. SBIRT won't stick because if we don't have the buy-in, if we don't have the connection to our mission and vision, then SBIRT has a way of falling by the wayside and getting lost. So one of the ways that we make sure SBIRT doesn't get lost is that we make sure that our workflows, they drive our practice integration, so that clinical decisions, they're supported through our policies and procedures, that we use things like reminder systems through our EHRs, and that we use that data. We use data as a way to monitor and provide immediate and as real-time feedback to our providers so that they can adjust either their behavior or the clinical workflows to make sure that we're doing what we need to do. So SBIRT requires the investment of training and retraining and then getting that stuff down, those guidelines, those protocols into policies and procedures so that they become part of the organizational culture. And that's what it takes to make SBIRT stick. So we're going to shift gears a little bit now and move into our MAT discussion. As we kind of, SBIRT's a nice segue to that. MAT leads us more to a different kind of approach to treating substance use disorders in primary care and integrated care, and more on the severe end of those substance use disorders. And when we talk about MAT, a lot of the talk right now is around the opioid epidemic and treating opioids. But if you're doing smoking cessation out there with nicotine replacement patches or the gum, or using medications like Chantix or Wellbutrin to treat smoking cessation, you're doing MAT. You're using medication-assisted treatment. There's some controversy out here around MAT and whether we want to call it medication-assisted treatment, what are they called therapy assisted treatment. But we're going to stick with MAT because it seems to be what's being used most in the field to help ease with communication. So for MAT, when I talk about it, and for our purposes here today, we're talking about 3 legs of the MAT stool, which includes medications, it includes recovery supports, and it includes behavioral health psychosocial supports. So psychotherapy. So bringing those 3 components as we talk about MAT. For us, it's not just about medication. It's not just about recovery support. It's not just about psychosocial support. It's bringing those together in the best way that the patient wants. And so I just want to make sure that that's an understanding. And really, MAT is ideal for integrated care teams because we're the ones who can provide all those components under one roof. And it changes the way, again, back to treating addiction over a continuum of care. We can use our chronic disease management model to fit perfectly in MAT. The idea that relapse is a component of addiction, that we know that many patients are going to experience a return to use, and using that as an opportunity, not as a failure, but similar to the other chronic conditions that we treat so effectively. So we know the relapse rates, although the impact of a relapse certainly can be greater when compared to chronic health conditions like diabetes or asthma or hypertension. Those rates sometimes are even better for addiction, but very much follow similar percentages. And so we have very strong care management programs, tools, techniques, and settings to help address addiction as a chronic health condition across that continuum. We know MAT is effective. It's an evidence-based practice. Using methadone and buprenorphine is the gold standard to treat MAT. It reduces overdose death, so important. It reduces risk of overdose, reduces drug use, prevents injection behavior, and reduces criminal behavior. So the evidence is out there. So what do we need to do? What do we need to know about if we are thinking about implementing MAT, or if we have implemented it and we're still kind of building the program? And many of the health centers out there are kind of building the program. It's kind of like building the plane as we fly it. It's just the way it goes because we're in such a fast-paced environment. So the things that we need to address are the economic environment, our own infrastructure, looking at our regulatory and policy barriers. Those can be external and internal, our environmental resources, and then our culture. So our economics, how do we keep the roof over our head? How do we have to make sure that the practices that we implement, that we offer, are sustainable. And so making sure that we know that the medications that we want to prescribe are reimbursable. So is there reimbursement for medication? Is there reimbursement for services? Fortunately, if you're working in an integrated care environment, this criteria usually matches up pretty well. But exploring and knowing your Medicaid and health plan formularies, which medications are covered, which ones are not, and for how long, are really important proactive questions. We certainly wouldn't want to start someone on a treatment that we'd have to take away and set them up in a way for failure. And so finding ways that we're going to address those gaps before we start our patients on those pathways is so important. And we know that most of our environments will cover these areas, but doing the preliminary work to check out those economic pieces is so important. And then on to our infrastructure. Our infrastructure is really about organizational readiness. How ready is our organization to implement that? And the questions that we need to ask is, are our prescribers comfortable with this? And typically the answer is no. We talked about our lack of training, our lack of support around addiction treatment and using these medications. There's concerns around providers that they need to, and rightfully so, protect their licenses, issues around how to handle diversion of these medications, and the overall understanding of addiction are things that proactively need to be addressed before we think about actually implementation. And then, do we have the behavioral health supports? And when I talk about behavioral health support, it's important that we provide, of course, supports to our patients, but behavioral health's role, a lot of times in MAT implementation, is supporting our primary care providers, the prescribers. So training our behavioral health staff on addiction, on opioids, on treatment planning, how to provide an assessment where we can quickly, concisely, and confidently communicate to our primary care providers all the information that they need to know and don't have the time to get. We can give it to them so they can feel confident about handling the medication management side of these of MAT. And so then utilizing our care coordination, our infrastructure. Like I said, we typically, integrated care environments have care coordination. How can we use that to treat substance use disorders? So effective. The physical space, thinking about things like, where are we going to store our medications? Can we store our medications in a safe place? Is that something we need to do here? Do we have a place for patients who maybe be here for typically longer visits if we do an induction, say, of buprenorphine? And then also our infrastructure of letting our board members, say, for example, the rest of our staff, communicating to our staff internally about MAT, educating them. There's a lot of mythology out there about medication-assisted treatment. Are we treating addiction with drugs with drugs? Are we trading one addiction for another? All those are very real concerns that we have within our own staff and within our infrastructure that really need to be addressed. Third piece are regulations, thinking about regulatory and policy considerations. How are we going to handle our patients' adherence to treatment? We know that maybe come up as an issue. Do we have a patient contract that they're going to sign? What does that look like? What does it include? What does it not include? We talk a little about an infrastructure, but storage and disposal of medications if we keep them on site. What's our policy around those things? Our consent to treat. Questions come up around confidentiality. Does that change our confidentiality, our information sharing, being able to answer those questions? How do we handle patient compliance to the program or their non-compliance, drug use, coming up with positive drug screens? If there's polysubstance use, how do we address that? Is it okay if patients smoke marijuana? Is it not okay? How do we handle the results of our drug screening? How do we get those things done? So our regulatory and policy consideration is very important. And then environmental considerations, really taking a step back from our infrastructure and looking out into the environment, our community. What community resources do we have? What is our community assessment? Are we starting to partner with, if we're doing MAT, with a community outpatient program? With if someone needs a higher level of care, with an opioid treatment program, an OTP, with someone who needs that higher level of care, like a residential environment. Are we making those connections within our community? Also connecting with our legal system. So many of our patients who are going to be on MAT, who are eligible for MAT, who would be candidates for MAT, are connected with the legal system. What implication does that have? Does that put them in jeopardy with their probation, with the stipulation of their PO? So those are things that we need to connect with. Other health centers, connecting with other health centers in our community that may be doing this work, who we can connect and get guidance from. Connecting also relationships with our hospitals, and overall, how do we improve our referral process if we need it, if we need that support? So connecting our behavioral health partnerships out in the community, other existing MAT providers, and then recovery supports. A big part for many patients, not all, but many, is the recovery community. And how comfortable is the recovery community with MAT? There's a lot of misunderstanding about MAT, a lot of mythology, bias, discriminatory behaviors around MAT. And this exists in many recovery support systems like AA, like NA. And so that may require that we bring the leaders from those programs into the health center to talk with them, because some of our patients are really going to benefit from that type of recovery support network. And so is there a way we can start to work with them? Same with faith-based supports. Such an important part for many of our patients. So it may involve a lot of community education on our part. And then finally, the fifth part, I leave it for last because I think it's the most important. I think it impacts all four other phases of MAT implementation, is culture. And really taking an honest look at our beliefs, our perceptions, and our judgments. And I throw Santa up here, it's that time of year. But what we believe is real. What we believe is what happens. And those beliefs, especially when it comes to addiction, can be based on mythology, can be based on misinterpretation, can be based on things that are just wrong. And so it is important that we start to find a way within our culture to have difficult conversations around our perceptions of MAT, around our perceptions of what and who a person with a substance use disorder is. Moving away from stigmatizing language. It is very challenging. We know from the research, it takes 15 to 20 years to implement an evidence-based practice. That every time I look at that statistic, it's still mind-boggling to me. We don't have that luxury when it comes to the opioid epidemic. We have hundreds of people dying a day from overdose death, and a big part of that is because of opioids, now onto fentanyl, the dangers of that. And so we need to really be aggressive in speeding up the process that it takes for culture shift. And so acknowledging the fact that 20% of what healthcare providers do is not based on evidence. It's based on things like gut, on feeling, on perception of what we know works, our clinical judgment. And while all those things are good and valuable, they need to be balanced with evidence-based approaches. And when we bring those two together, that's why screening and SBIRT works so well. When we bring those tools together, that's when we're at our best. And that's what helps us shift our culture. And that's what it's going to take to impact this opioid epidemic. And so we're built for this. And so addressing bias, addressing stigma, addressing discrimination, addressing those negative stereotypes. Stigma really is the judgment that we have. That's how we think. Stigma changes when we behave differently. When we behave differently, that's discrimination. Those are the behaviors that result from the way that we think. And so this is when we treat people differently. And I use this graphic here because I can think of no other group that is more discriminated against than people with substance use disorders, and especially women who are pregnant. We hear it all the time. How can she do that? How can she do that and continue to use it? She doesn't care about herself. At least she should care about her child, her unborn child. And that right there is a misunderstanding, because if we're talking about addiction, addiction is no longer about a choice. We've lost our ability to choose. That is a judgment or an evaluation of someone who has a neurobiological behavioral brain disorder. So educating ourselves is going to really challenge our shift and our approach. We now know that substance use disorders are not a moral or spiritual failing. They're not a lack of will or responsibility. They're not a character defect. Yet when I was trained in substance use disorders, these were some of the basic building blocks of treatment planning and approaches to care. And we know that there's no such thing as an addictive personality type. And this last part is really gonna, I think it really challenges us. It still challenges me today in the way I think about addiction, substance use disorders, is that addiction does not have personality components such as denial, rationalization, defensiveness, manipulation, or resistance, or any other abnormally robust defense mechanisms. So what that's saying is that I was operating on a lot of misunderstanding of what substance use disorders are. And this is from SAMHSA. This is information from SAMHSA. The references at the bottom of the slide if you want to check it out. So really impacting that culture is going to be a big part of what we do. So it's the strength of the integrated care team that has the potential to really change these things. And utilizing our integrated care approach to substance use, it's about whole health. It's not just going to impact substance use disorder. It's also going to start to, through SBIRT, help you identify problems you didn't know were there, and also address the problems that you do, like severe addiction. And so it's going to help improve those patients that are not responding to our typical interventions that we're treating for diabetes. How many of the patients that we are treating for GI issues, constipation, IBS, acid reflux, GERD, all those things are connected to substance use disorders. Things like hypertension, and especially we see this in chronic pain. What the close connection that we have with chronic pain. And we now know chronic pain, a major component for many of the patients that we're treating through using opioids, can more effectively be treated through behavioral health interventions because of central sensitization. And we're not going to go into central sensitization, but if you haven't heard of it, check it out. We're probably going to have a webinar in the next couple of months on it because it's so important. It's something, again, that we misunderstand. But our integrated care teams are built for this. We're built to address these issues. And then also, too, sleep problems. How many of our patients have sleep problems? Addressing these issues as a whole in a continuum is so powerful. And because we have an integrated care model, we're built to address these things in a way that is very unique and very different. So I'm going to end here. It's about 12:43. I know folks are busy. And so that's going to wrap us up. I'm going to wrap up and then take a look to see if we have any questions from the webinar. Please, if you do have questions, I forgot to mention in the beginning, but go ahead and send those through in the chat. I see a couple have come up. But just as a wrap up, there will be, as you close out, a survey at the end. Really helpful if you fill that out. It takes a couple of minutes. It's mostly just clicking, but it's an express survey. And really, we're basing our next our webinar, and we're going to have these monthly webinars based on topics that are really important to you folks that are doing the work out there in the field. Also, we're going to have a mailing list. We decided to just make it a Integration Express email that goes out once a month. It's going to be an effort to keep you up on the latest evidence-based practices, changes that are going on. For example, UDS screening, there's some new measures that are coming out. We're working through that here and going to bring you that information. We're really limiting it to one email per month because we know we're all overwhelmed with information overload. And so you can rely on that email once a month to grab the best information we have from the last 4 weeks and give it to you. And so I hope that you'll think about joining us next month for our webinar. We have the date set, but we don't have the topic because we're waiting for the feedback. And then finally, if any of you have any questions or want to talk to me in greater detail about what's going on at your health center around these things, don't hesitate to reach out. You can shoot me a text, send me an email, or give me a call directly. I'm happy to do that. But I'm going to go ahead and take a look at some of the questions here. So there's a great question here. Melissa's asking a question: is there a recommended way to screen for e-cigarette use in adolescents? I only saw a tobacco question on SBIRT. Melissa, that's a great question. And the psychologists are going to get maybe a little bit upset with me, and the purists get a little bit upset with me, but I think Melissa's question really speaks to cultural competence. You know, when we ask these questions on whatever screening tool that we're using, we have to shape it sometimes for our community. And we are the experts on our community. You know, I was working with a health center in Louisiana, and they were screening their adolescents for using the S2VI. And they realized that they had to use the specific word mojo. Mojo was the terminology that the adolescents were using, and to further complicate it, mojo was a synthetic. And I don't know why we call it synthetic marijuana, because it's got nothing to do with marijuana. These are mostly chemicals, but it's a synthetic marijuana, and so they realized they had to adapt their questions to make sure that they asked that question. So, you know, what's our goal? Our goal here is to make sure that we screen our adolescents and adapt that questioning in a way where it meets the needs of our particular culture. We have another question on here. We'll get the slides. Yes, we'll be emailing out a copy of the slides. They're also going to be available once we finish the webinar up on the website. You can have that. And so, yeah, there's a couple of questions on slides. One other question here on the webinar. It says, how do you handle when patients get offended if we ask about drug use or drinking? That's such a great question. Thanks for asking it. You know, one of the things I think that is so important is that to acknowledge that there's an anxiety, there's a fear of talking to our patients about substance use. And so one of the ways that we can make our patients feel comfortable is when we train our staff so that they feel confident in asking these questions. When we ask these questions in a way where we feel confident, when we talk to our patients, when we feel confident, they pick up on that. And so making SBIRT part of our health center culture really changes the vibe. It really changes the way that we can talk to our patients, and then also talking about substance use disorders like we do other chronic health conditions, taking away a parental punitive approach and being supportive and strengths-based, using motivational interviewing spirit to talk about these things is a game changer. And then finally, the best screening that we can do, especially when it comes to adolescents, is self-administer. When we don't directly ask the questions, the research tells us that the more we can get patients to fill these screeners out on their own, the more forthcoming they are with information. And that can be a real game changer. I think it's especially important when it comes to adolescents. And there's another question here. I'm going to check on MAT. This is a great question. I'm going to read it out loud for us. I'm wondering, from our FQHC perspective, if we did implement MAT, would we then fall under substance use treatment provider if we integrated setting, offer consulting in line with medication? So this could be a potential next webinar for us. This is a great question. I think what the question may be getting at, I could be wrong here, is do we fall under 42 CFR or do we not? And this is a very big question that we could talk quite a bit about. So I'm going to answer it this way the best that I can. The way to manage this issue, if I'm hitting this correctly, is that if we make sure that we include in our original consent forms with our patients, our consent to treat, that we are an integrated care setting and will they give us permission to disclose, like we asked for, HIV/AIDS information, that we also include specific sign-off on substance use disorders. We primarily are covered no matter whether we are designated as 42 CFR or not. So the idea is that we are addressing at the highest level, highest criteria to make sure that we are in compliance. 99% of the patients that come to your health center are going to be okay with this. They're going to sign off on it. 1% won't, and if they don't, I think it's a great opportunity to talk about them, what their concerns are, what's going on there, how can we help support them around this issue. And then we have to find a way to flag that chart, to mark that chart, to make sure that we don't provide, disclose that information the way we don't want that patient to. So it's an anonymous request on that question. I hope the FQHC question. I hope I'm answering it in the way that, in the spirit that it was asked. And Melissa's responding back about the SBIRT screening question for the e-cigarettes, is that she's saying we developed our own SBIRT consents. Oh, she's responding to that other one. We developed our own SBIRT consent and trained our community health center teams. Melissa, thanks for helping out on that. And thanks so much for the interaction and feedback. And also for getting up very early in the morning. I know Melissa's calling from a far, far place away, so thank you. We have a couple other questions that came in. See if we have time for that. We do. What do we do if a patient refuses to fill out the Audit C? Again, great question. You know, looking at patients who refuse to do something is an opportunity for us to talk with them, to develop relationship, and really bringing that spirit of MI into what's going on for this patient. Looking not as resistance or non-compliance, but for us opportunity to engage and understand at a deeper level that this behavior, this choice, may be a symptom of something else going on. So, you know, one of the things that I love is switching out the word non-compliance. You know, taking non-compliance out and really looking at non-compliance as a symptom. That we don't use the word non-compliance, but looking at those behaviors as a symptom of something else going on is a great way to address those things. So thanks for that question. Another question then around SBIRT. Who's supposed to complete the brief intervention? Is it the primary care provider, a specialist, or a behavioral health provider? Another great question. So the way I'd start to answer that is that we, because of our limited time, our limited resources, the phrase that we use is, let's get everyone working at the top of their license. Meaning that anything that a behavioral health provider can do, we don't want a primary care provider can do. And anything that a nurse can do, we don't want a behavioral health provider or primary care provider, and so on and so on and so on. Extending to community health worker, peer supports, patient navigators, community health workers. All of us as a team, integrated team, working at the top of our license is ideal. And so anytime we can assure that a primary care provider doesn't need to do those things is ideal. However, I will say that this comes down a lot to clinical judgment. Brief interventions don't need to be necessarily long things. You know, we have a tool that teaches us how to do a brief intervention in 60 seconds. So primary care providers sometimes may initiate that BI. And so sometimes the primary care provider does it, and other times it's a warm handoff, where it's a more intense type of discussion and intervention. And I think that's something that really speaks to how you build your level of integration, of being beyond, as an integrated care team, the traditional roles of what a primary care provider does, what a behavioral health provider does, what a nurse does, what an MA does, and on and on and on. And that we all share roles and responsibilities and are able to flex in and out of those roles depending on all the different conditions that we face on a given day or a given hour, half an hour in a health center. So what determines who does the BI may be time. If I'm a primary care provider, and I know this doesn't happen for anyone, but is, cruising along and on time, not running late, has a spare few minutes, and the behavioral health provider's backed up with 3 warm handoffs or waiting in rooms, an integrated care team says, hey, as a primary care provider, I'm going to cover for my social worker or my psychologist. I'm going to go ahead and do this BI. Versus the other way, where a primary care provider is backed up an hour and there's a wait, the wait right away, that can be a warm handoff where I call my behavioral health provider and they come in and do that BI, and that primary care provider can trust in the fact that that's being taken care of, and they get to go to their next appointment to save time. So that can be a really dynamic, that's a dynamic answer for dynamic situations that we deal with every day on a day in, day out basis in integrated care. So I think we have time for maybe one more question. We have it here. What if an adolescent discloses through SBIRT that he's using drugs, but he's scared and doesn't want to tell his parents? Well, this is another great question that comes down a lot of times to specificity around community culture and also knowing individualized patient, knowing individualized care. So in the brief few minutes that we have to answer this, what I would say is that we don't have to tell we can maintain confidentiality with our adolescents as long as they don't meet that criteria that we are worried about their welfare or danger to their self. Now, what that means can depend on a lot of different variables. So I won't make a blanket statement to say just because an adolescent is using a certain drug doesn't mean you have to report them to, have to disclose to the parent. However, I will say that your ability to develop a relationship and build trust with that adolescent can be a really important component to them feeling forthcoming about that information. And so one of the ways to work with your adolescents is and to feel confident so that everyone's on the same page and to secure that confidentiality is to get parental permission to say, hey, mom, dad, or caregiver, whoever it is, are you okay if I talk with your son or daughter and that what we talk about stays between us? And that if there's any concerns about their danger, that I'll come to you and talk to you about it. Again, most times parents are really relieved that you do that, that they're willing to do that. And so I think that's a great intervention to kind of help manage sometimes a difficult situation of making sure that we keep appropriate boundaries, that we disclose what we need to disclose, and also create a safe space for our kids to talk about the things that they need to without their parents around. So I hope that helps answer that question. I'm going to go ahead and wrap up here. I know folks probably have to jump off and get to their next tasks or on with their day, but I just want to thank you all so much for the work that you do in your communities. It's incredible work, it's hard work, but it's such rewarding work. And so I hope you'll stay connected with us at NSI Strategies to help support you along that way. And if I can be of any assistance to any of you, please don't hesitate to reach out to me. And hopefully I'll see you all in a month for our upcoming webinar on integrated care. Thanks so much.